Hey everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. A few more things. We talked about a lot of the BLS preparation, but let's talk about that ALS preparation, right? For our advanced EMT. We'll talk a little bit about advanced EMTs, but mostly for the paramedic providers, right?
I think the most important thing to think about preparation is you prepare to fail.
Yes.
Yeah.
Yeah. What's the backup plan, and what's the backup plan to the backup plan, right?
What are all your backup plans?
And are they out in place, ready to go, not in the bag, zipped up in this compartment where you cannot reach for it immediately?
Correct.
You know, one of the things I'll give Katie Uropoli credit for from AirMed is she would always teach and still teaches that your first attempt is your best attempt and you need to make it so. But prepare to fail. Yeah.
Yeah.
And we'll talk about, you know, all the preparation. Specifically with endotracheal intubation, we do a few positioning things different than putting a, you know, where if we were putting a king airway or we put a supraglottic, an iGel, something in here, we would want this head in a neutral position. We want different positions when we're trying to visualize the airway. That's because we're talking about a different set of circumstances. But the overarching piece here being resuscitate, then ventilate, right? For all those aforementioned reasons, right? You know, we're transitioning them from negative to positive pressure. We're taking away preload. You know, if they're already shocked or nearing shock or, you know, in some precipitous, you know, downturn already, we need to right that ship before we take their airway, because basically all the stuff that we can do here is just going to add insult to injury, right? It's
correct.
You know, your point said a little bit different way. So, get vascular access, whatever that turns out to be, IOs, IVs, EJs.
Vascular access.
Yeah.
2, 12, right? Okay, not to 12.
That's a bit much.
10 might be okay, but not 12. You know, get access first. You know, get your vascular access, fluid resuscitate as necessary, right? Have your backup plans, have your drugs drawn, right? If I'm doing direct laryngoscopy, I'm concerned about vagaling this patient down. Maybe I've got some atropine laying out, right? Some push dose epi, right?
You can free draw medications?
Oh my God, that's a thing, isn't it? You mean you can open the box and like put things together and tape?
What if I don't use it? I can waste it?
Oh my, no, that's not a thing. Wow. That can't be a thing.
I never thought about that.
Now, if I may, my personal practice is I know I might stimulate some vagus tone. Let's say I've got a partially awake patient or something like that, and I'm concerned about bringing heart rate and blood pressure down.
Well, especially on your kids.
Atropine is, of course, clinically indicated for that. But I have another drug that I can do pretty much everything with, and we use more often, which is the push dose epi, right? I'm going to get similar effects by different mechanisms, very different mechanisms, out of both. My keep it simple, stupid response is I just push dose epi, right? I have the...
Just have it ready. Have it mixed.
If I have post-airway hypotension, post-airway bradycardia, rather than was this because of vagal tone, was it not, was it something else? Rather than, it's cognitive offload for me, because I know I can cover all the bases with the one medication rather than just the one thing, which is the acetylcholine released by me stimulating the vagus nerve, right? I know that's all it's going to address. If I have other contributory factors, may not do exactly what I need it to do, I can do everything with the push dose epi, rate and pressure.
All in one.
Personal preference, right? But something to think about as you're setting up. Do I need all these things? Do I need half these things? Can I make my life easier?
That's one of the beauties of using ketamine as an adjunct.
Yeah, absolutely.
For your intubations, because you're going to get the pain with that. So in the hospital, sometimes we'll give pain medication, fentanyl, to help stop that irritation of the back of the throat to cause the vagus stimulation. So ketamine will help with that as well.
Absolutely.
So in preparation, what I like to see is obviously you're going to have your first pass attempt, and I think probably something that maybe not coming officially in 2024, but we're probably going to look at is probably using bougies more in our intubations attempts. If you're looking at the high functioning critical care organizations out there, they use bougies for every attempt.
Every attempt, correct.
Not my practice. I didn't train that way. Not that I shouldn't be doing it, but I also the having the access to a bougie is important, but also knowing how to use the bougie, know what it's supposed to feel like, and that's why the people that are very pro bougie are pushing for every time, so that way you're familiar with
Correct.
that tool and how to use it. So that way I know how this feels. I know I'm there. I'm in.
Right.
I know how to get it.
Yeah.
But I can look at an airway and go, nope, this is going to be difficult. I'm in there. I just need my bougie. Bougie first passed, tube over top, we're in. But my bougie's out and it's open. It's right there.
Correct.
Absolutely.
I agree. I
But,
did a
but
similar
like you
thing,
said,
too.
with bougies, you got to know your equipment. Does it have a coude tip? Does it not? Know if you're going to even get a tracheal click when you get in, because I've never felt it when I've used it. I know people say they have. I haven't. But know that if you're going to get it, you're probably going to hit the carina. It will probably stop short. If I did the belly, you're probably going to lose it. So, I mean, there's indications out there. Just study up on it, practice with it, use it. It is in the protocol. It's in the vending machines.
The broader discussion there is practicing with multiple tools, right? So you are bringing, you're bringing up the one mindset of many groups. I've read very similar things to what you're referring to, which is they just do the same thing every time, expecting worst case. That way, it's always consistent, and then your numbers are always hit, right? Because
But when they look at bougie versus not bougie, it's the non-bougie group is always less.
Always,
and it always
correct.
comes to the fact that they don't know how to use it. They're not familiar enough with that tool. So that's what the difference is, right?
And
knowing how to use your tool.
Like everything, though, you need to know how to use your tool. And that goes back to training. That goes back to education.
I wanted
Hands-on training.
Repetitive use. I mean, how many times do we practice bailout drills with the fire department or blacked out masks and doing something? Why are you not using the bougie or just tubing? Or do you know how to form your stylet?
I want to extrapolate that whole conversation out to even, let's say, direct laryngoscopy versus video, right?
Yeah.
All right, maybe we've been using video as a crutch for a long time, and for the last couple of years, that's all we knew. And you should practice and be good at it. I'm not saying
then it's broken.
then it's broken. Then it's fogged. Then there's
batteries are
vomit.
dead.
The batteries are dead.
Yep.
Reasons.
Failure.
Reasons. Bleeding into the air. Right. Insert reason here. Right.
Yep.
I have to transition back to DL
Whole skull.
to direct laryngoscopy.
Or-
Right. Somebody hands me a Miller 3. Right. No, that's not what I practice with, right? Take the opportunity when you practice to practice with multiple things, right?
Yeah.
I'm a Mac guy. Well, I got
choose,
buddy.
choose to be an expert in something, right? So, like, I'm a Mac 4 guy, right? That's just
Yep.
hand me a Mac 4.
Well, you get a Mac 4, you got every blade size and
Pretty much, right. But this, this patient's 1,200 grams. Mac 4's fine. I'll make it work, right?
And you should probably talk more about why it works for every size at some point.
Go
but
right
yeah,
ahead.
well, you fingers, Mac
1, 2, 3,
would be
4.
nothing, and 1, 2, 3, 4. Yeah,
right? Yeah, just where you choke up. But I've chosen to be an expert in that. However, do I still practice with everything else? Yeah, when I have the opportunity, right? It's like, okay, give me a Miller, let's do this different
he's
way.
not joking either. He's literally stopped to the firehouse, and him and I have sat down at a computer and
fussed with
looked at
stuff.
videos of
And
airways
fussed with
and
stuff.
messed with equipment. So yeah, we screw around with that when we get chances.
But know those tools, and if you choose to do and I'm similar to you, is I'll uncage it. I'll have my bougie sitting there, but I choose on a per case basis if
I need it.
If I need it, I see there's intellectual value to me. Like, I probably should just do it every single time. Then you don't have to think about it, right?
Well, are you setting up suction before you intubate?
Yes.
I'm generally good about that.
Right. So, I mean, but it's just one of those, are you attaching your oxygen to your patient? Are you getting the nasal cannula on? Are you ramping? I mean, this all goes back to checklists, like Dr. Hill alluded to. How often are you looking for Malman-Patty scores? Yeah, I think you should be familiar with them, and I think you should document them. But like you said earlier off recording here, I mean, you can look at a patient and say this is gonna stink.
You should know what those scores are and how it's going to judge whether or not this is going to be an easy or more difficult airway. And then once you get experience, once you've had 20, 30 years of experience, you're going to get really good at just sizing them up.
Eyeballing it.
This one's gonna stink.
Yep.
Yeah, let's make sure we talk about that when we talk about intubation, specifically. But I think they're simple. Like, I don't. Let's talk about that in intubation. There's a bunch that go into that. So any other preparatory stuff before we get into the supraglottics, right? So we've taken the time, hurried up and slowed down, right? We're bagging the patient appropriately at appropriate rate with appropriate depth just to make rise and fall of the chest. We're monitoring pulse oximetry and capnography, understanding the limitations and the benefits of either or both.
Well, you've got your leads on. We've
got our cardiac monitor on, absolutely.
You've exposed the chest so you can see chest rise and fall. I mean, that's important too.
That
We
is
don't
also-
do that
yep.
often.
You got at least two points of access in the patient.
Right, resuscitate before we intubate, or I'm using that loosely before you do anything to take their airway, right? Get all if you are in fact intubating, and if you're using agents, have those agents prepped. Have your backup agents prepped if you need vasopressor support or something down afterwards. Have all that pre-bolus the patient if their blood pressure is already soft. Build yourself some wiggle room.
Augment the O2.
Passive oxygenation.
Pre-oxygenate. Put that nasal cannula on. Pre-ox the hell out of them. If they're already on CPAP, if they're already on BiPAP, if they're already on something else, augment before you transition them over.
And know how to use your equipment.
Yeah, absolutely.
I think one thing to know about preparation, though, is if your patient's awake and talking, it's a respiratory distress, like, ask them, have you been intubated in this situation?
That's a great point.
Because you know whether or not we're going to be going down that road. Ask family members if the patient can't talk, have they ever had intubated in the past, ever difficulties with surgeries. If you're an RSI, to ask have you ever had surgery before? Have they ever told you about some medications you should or shouldn't have? Making sure that you get that information before you express an RSI, before you make them unconscious and before you paralyze them.
When did they eat?
Yeah.
When did they eat, if they've eaten?
And how much?
There's value in assuming everybody just ate.
Yes, because
Right.
they just did.
They just did, but
McDonald's is having a sale, 2 for $1 Big Macs, and that's just what I eat.
mine.
Oh, fillet of fish.
No.
Nuggets. I like the nuggets.
My nemesis has been red sauces,
Yeah.
marinara, spaghettis, stuff like that. And that's just. But anyway,
What'd you have to? Oh, cold cuts today.
So one of my squadrons had a really bad case, and they had a massive PE, and they were bleeding large volumes of blood coming from the airway onto white carpet.
oh,
Ugh.
So that can also happen, right?
Yeah. Yeah.
and then we did talk a little bit about preparing suction, but
Suction assisted intubation.
maybe we need to talk about we probably need to touch a little bit of on are there times where you just have to bury a catheter and kind of work around it.
Well, and
there are,
for
of
the
course.
love of God, don't forget your biads. I mean, they're blind insertion airway devices for a reason. Don't man up. Say, I'm a paramedic. I have to get this tube through the cords. We got better tools that.
Well, yeah. When we get into the supraglottics, we'll bring up that topic. But that's exactly it. Is you've got other options. There's pros and cons with it, but yeah, you've got options. So, anything else before we transition to the?
I think supraglottics.
I think we're on to supraglottics.
Yeah.